Clinical chemistry, therapeutic drug monitoring. The purpose of therapeutic drug monitoring is to ensure that the drug dosage is within a range that produces maximal therapeutic benefit, known as the therapeutic range, and 2, identify when the drug is outside of the therapeutic range, which may lead to drug inefficacy or toxicity. For most drug therapies, safe and effective dosage regimens for the majority of the population have been established, and TDM is unnecessary. The standard dosage for a drug is the dose providing therapeutic benefits as statistically derived from observations in a healthy population. Patient age, gender, genetics, diet, prescription drugs, self-administered over-the-counter drugs, and even naturopathic agents can influence drug concentrations and efficacy. TDM may also be used to identify patients who are non-compliant or reoptimize a dosing regimen based on drug-to-drug interactions. This is an overview of the factors that influence the circulating concentration of an orally administered drug. So GI absorption directly impacts the circulating free drug, and then the distribution of the site of action, which produces a biological response, the elimination due to renal excretion or metabolism. Metabolism can lead to metabolites, and then those metabolites can be excreted through the renal system, and then also protein binding. Routes of administration, I'm sure you are all familiar with these, but we're just going to go through these briefly. Intravenous, IV, is injected directly into circulation through a vein. Intramuscular, IM, is injected into muscle. Subcutaneous, SC, is injected just under the skin. Transcutaneous is inhaled or absorbed through the skin. Suppository is given by rectal delivery, and oral administration is by mouth. For orally administered drugs, efficacy of absorption from the GI tract depends on many factors: dissociation from its administered form, solubility in gastrointestinal fluids, and the diffusion across the gastrointestinal membranes. Uptake by transport mechanisms intended for dietary constituents versus passive diffusion. Changes in intestinal motility, pH, inflammation, food, or other drugs. For example, if the patient has diarrhea, they're going to have increased intestinal motility, and they may not be able to take up the drug enough. Sometimes patients who are given certain types of pain medications will become constipated, and combine that with certain other types of medications can lead to toxicity of those other medications, because the medication stays in their digestive tract a little bit longer, as opposed to excess amounts being released in the feces. So having that those constipating medications can lead to an increase in toxicity and can cause issues within those patients. Variation among population, as drug absorption rates may change with age, pregnancy, or pathological conditions. Drug distribution is subject to diffusion out of the vasculature and into the interstitial and intracellular spaces. It's largely dependent on the lipid solubility. Volume of distribution index is used to describe the distribution characteristics of a drug. Free versus bound. Most drugs in circulation are subject to binding with serum constituents. Only free or unbound fraction of the drug can interact with the site of action and cause a biological response. The free drug fraction is also termed active. Percentage of free depends on the physiologic and biochemical parameters. Albumin represents the majority of protein constituents in plasma, and changes in its concentration can affect the free versus bound status of many drugs. Fraction of free drug may also be influenced by the concentration of substances that compete for binding sites, which may be other drugs or endogenous substances such as urea, bilirubin, or hormones. Drug metabolism. Substances absorbed from the intestine, except the rectum, enter the hepatic portal system. Circulating blood from the gastrointestinal tract is routed through the liver before it enters into general circulation. Drugs are subject to significant hepatic uptake and metabolism during the passage through the liver. This process is known as first-pass metabolism. Particularly important consideration if the efficacy of a drug depends on the metabolic generation of a therapeutically active metabolite. Biochemical pathway responsible for a large portion of drug metabolism is the hepatic mixed function oxidase MFO system. Drug elimination. Drugs can be cleared from the body by various mechanisms. The plasma-free fraction of a parent drug, or its metabolites is subject to glomerular filtration, renal secretion, or both. It's independent of the clearance mechanism. Decreases in the plasma drug concentration most often occur as a first-order process, indicating an exponential rate of loss. First-order elimination follows the following general equation, which you can see equation 30.2 in the textbook. Drugs are eliminated through hepatic metabolism, renal filtration, or a combination of the two. So first-order drug elimination, you can see the plasma concentration on the left, and as time goes on, the plasma concentration is going to decrease. Pharmacokinetics. The activity of a drug in the body is influenced by absorption, distribution, metabolism, and excretion. Most drugs are not administered as a single bolus. They're delivered on a scheduled basis, for example, once every 8 hours. The blood drug concentration oscillates between a maximum and a minimum. Peak drug concentration and the trough drug concentration, respectively. Approximately 5 to 7 doses are required before a steady state oscillation can occur. Specimen collection. So accurate timing of specimen collection is the single most important factor. In general, trough concentrations are drawn right before the next dose, and peak concentrations are drawn 1 hour after an orally administered dose. Must always be used within the clinical context of the situation. Serum or plasma is the specimen of choice. Some drugs have a tendency to be absorbed into the gel of certain separator collection tubes. So if you recall learning about the different types of blood tubes, the red gel that has that gel substance that will separate the serum from the rest of the blood sample, some drugs can be absorbed in there, and that's going to obviously affect the concentration when we go to measure that in the lab. Pharmacogenomics. Responders, patients benefiting from therapeutic and desired effects of drug. Non-responders are patients not benefiting from therapeutic and desired effects of the drug. Therapeutic effectiveness of drugs has been attributed to inter-individual variation in genetic polymorphisms of drug metabolism pathways. Cytochrome P450 gene group family member that affects drug metabolism. It's a family of enzymes within the MFO system. Pharmacogenetic profiling can also be used to predict drug-to-drug interactions. So now we're going to go through several types of drugs that are typically going to be relevant for TDM. So first, cardioactive drugs. Digoxin or lanoxin is a cardiac glycoside used in the treatment of congestive heart failure. The purpose, again, it's used in the treatment of congestive heart failure. How it functions, it inhibits membrane sodium-potassium ATPase. Absorption is variable. It's influenced by dietary factors, GI motility, and formulation of the drug. Elimination is by renal filtration of plasma-free form. The half-life in plasma is 38 hours in the average adult. Measurement, immunoassay to determine the total concentration in serum. Newborns, pregnant women, and patients with uremia or late-stage liver disease produce an endogenous substance that cross-reacts with the antibodies. Other cardioactive drugs. Quinidine is a naturally occurring drug used to treat various cardiac arrhythmias. Most common formulations are quinidine sulfate and quinidine gluconate. It has a half-life of 6 to 8 hours and is primarily eliminated by hepatic metabolism. Procainamide is used to treat cardiac arrhythmias. N-acetylprocainamide, a hepatic metabolite of the parent drug, demonstrates antiarrhythmic activity similar to procainamide. Disopyramide is another antiarrhythmic agent used in the treatment of cardiac abnormalities. It's used as a quinidine substance when quinidine's adverse effects are excessive. Antibiotics. Aminoglycosides are a group of chemically related antibiotics used to treat gram-negative bacterial infections that are resistant to other less toxic antibiotics. Most common include gentamicin, tobramycin, amikacin, and kanamycin. Most serious effects of aminoglycoside toxicity are nephrotoxicity and ototoxicity. Administration is generally admitted IV or IM injection, therefore these drugs are not used in an outpatient setting. When we say nephrotoxicity, we're talking about the nephron tubules in the kidneys, and oto is referring to the ear. Teicoplanin is a bactericidal antibiotic effective against both aerobic and anaerobic gram-positive bacilli, as well as gram-positive cocci. Proven effective in the treatment of methicillin-resistant Staphylococcus aureus, or MRSA. TDM is not routinely performed for teicoplanin, as a relationship between plasma concentrations and toxicity has not been established. Vancomycin is a glycopeptide antibiotic effective against gram-positive cocci and bacilli infections. It's administered by IV infusion. Toxicities of vancomycin include red man syndrome, nephrotoxicity, and ototoxicity. Red man syndrome is characterized by an erythemic flushing of the extremities. Antiepileptic drugs, phenobarbital and primidone, a slow-acting barbiturate that effectively controls several types of seizures. Primidone is an inactive proform of phenobarbital. Primidone is rapidly absorbed into the GI tract and converted to its active form, phenobarbital. Primidone is performed over phenobarbital when steady-state kinetics need to be established quickly. Phenytoin and phesophenetoin, a commonly used treatment for seizure disorders. It's used as a short-term prophylactic agent in brain injury to prevent loss of functional tissue. Phesophenetoin is an injectable proform of phenytoin that is rapidly metabolized to form the parent drug. Valproic acid, or valproate, is used as a monotherapy treatment of petit mal and absence seizures. Carbamazepine, an effective treatment in various seizure disorders. Because of its serious toxic adverse effects, it is less frequently used, including rashes, leukopenia, nausea, vertigo, and febrile reactions. Ethosuximide is used for controlling petit mal seizures. Effects of toxicity include nausea, vomiting, anorexia, dizziness, and lethargy. Felbamate is primarily indicated for use in severe epilepsies, an orally administered drug that is nearly completely absorbed by the GI tract. It's known for its toxicity and is primarily indicated in severe epilepsies, such as Lennox-Gastaut syndrome and refractory epilepsy. Gabapentin may be indicated as a monotherapy or in conjunction with other antiepileptic drugs in patients suffering from complex partial seizures, with or without generalized seizures. Lamotrigine treat patients with partial and generalized seizures. Levetiracetam indicated in partial and generalized seizures. Oxcarbazepine, a prodrug that is almost immediately metabolized to lisocarbazepine, indicated for monotherapy of partial seizures and in secondarily generalized tonic-clonic seizures. Tiagabine is used in the treatment of partial seizures. Adverse central nervous system side effects have been noted, including confusion, difficulty in speaking clearly or stuttering, mild sedation, and tingling sensation in the body's extremities, or paresthesia, especially in the hands and fingers. Topiramate is indicated in partial and generalized seizures, and zonisamide indicated in partial and generalized seizures. Psychoactive drugs, lithium, orally administered and used to treat manic depression. Tricyclic antidepressants, a class of drugs used to treat depression, insomnia, extreme apathy, and loss of libido. Clozapine, an atypical antipsychotic used to treat otherwise treatment-refractory schizophrenia. Olanzapine is a phenobenzodiazepine derivative that effectively treats schizophrenia, acute manic episodes, and recurrence of bipolar disorders. Cyclosporine, primarily clinical use suppression of host versus graft rejection of heterotropic transplanted organs. Its other immunosuppressive capabilities are, my mom was actually taking this for severe autoimmune eczema, and she was on this for many years, and eventually it ended up causing her renal failure due to toxicity, so she has now switched drugs, but cyclosporin has that effect, especially after long-term use. Tacrolimus, FK506, 100 times more potent than cyclosporine. Sirolimus, an antifungal agent with immunosuppressive activity, FDA approved for patients receiving kidney transplants. Mycophenolic acid, a lymphocyte proliferation inhibitor, used most commonly as supplemental therapy with cyclosporin, and Tacrolimus in renal transplant patients. Antineoplastics. Methotrexate, one of the few antineoplastic drugs in which TDM offers benefits to a therapeutic regimen. High-dose methotrexate, followed by leucovorin rescue, has been shown to be effective therapy for various neoplastic conditions. Basis of this therapy involves relative rate of mitosis of normal versus neoplastic cells. Neoplastic cells divide more rapidly than normal cells, have higher requirement for DNA, and are susceptible to deprivation of this essential constituent before normal cells. Efficacy depends on controlled period of inhibition accomplished by leucovorin. Bronchodilators. Theophylline is used as a treatment for respiratory disorders such as asthma and stable chronic obstructive pulmonary disease. Patients with difficulty using an inhaler or those with nocturnal symptoms. Serious adverse effects include insomnia, tachycardia, seizures, arrhythmias, and possible cardiorespiratory arrest.